So from our department, Dr. Lohita Jasti is going to present an interesting case of opsoclonus myclonus ataxia syndrome. So basically this is for teaching purpose and how to approach the syndromic presentation and what is the phenomenology and what is the systemic algorithmical approach to a case of myclonus or ataxia. So that is the point of discussion today. And for this, we have masters, our Dr. Neeraj Kumar, Professor Neurology, AIMS Bibinagar. And along with that, with ourselves also, we are having Dr. Lakshya Jyoti Baswandarai from the Assam. So welcome everyone. And now I would like to request Dr. Lohita to start the presentation. Dr. Lohita, are you there? Yeah.
Yes, sir. Um,
Okay.
um, Good evening, everyone. I'm Dr. Lohita Jasti, DM resident from
Hello.
IMS in some hospital. I'm presenting a case today. Um, my patient, who's a 26-year-old female, who's a right-handed individual, who's a housewife by occupation and hailing from West Bengal. And the informant is her husband and herself. Chief complaints. She presented with chief complaints of fever since the last 10 days, involuntary jerky movements of all four limbs since the last 4 days, and difficulty and imbalance while walking since the last 2 days. Patient was apparently all right 10 days back. Then, to start with, she developed high grade intermittent fever associated with chills and rigors, vomiting, and holocranial headache, which was relieved with medications for 3 to 4 hours. Uh, and then it would recur again. There is no associated blurring of vision, rash, involuntary movements, cough, diarrhea, burning micturition, or altered sensorium. She was then taken to a local hospital for the fever, where she was started on paracetamol and some empirical antibiotics, after which the fever has improved, where the frequency and the grade of fever has decreased, but it has not completely subsided. And there were no documents available. 2 to 3 days after that, she developed blurring of vision and sensation of objects moving around in both the eyes, which was not associated with any double vision, retroorbital pain, redness of eyes, or tearing. The family members have also noticed that there were some abnormal eye movements in her eyes. During the same time, she developed abnormal, involuntary, brief, jerky movements of the whole body. And these movements used to occur mostly during activities while she was trying to sit and stand. It was associated with frequent dropping of objects from her hand, and these movements were absent during rest and sleep. There was no aggravation with loud noise or bright lights or touch. These movements were not associated with any loss of consciousness, urinary incontinence, frothing from mouth, tongue bite, or any altered sensorium. The next day, she noticed unsteadiness while walking in the form of swaying to either side. She was also having clumsiness while performing her daily activities, like smearing of food over her face while eating. She also had slurring of speech, but the speech was still comprehensible. There was no undue exacerbation of this imbalance with darkness or with eye closure. There was no associated tingling sensation or numbness of feet. And she was able to perceive the floor while she was trying to walk. And there was no associated tinnitus, ear pain, discharge from the ear, or decreased hearing. Her bowel and bladder were normal. And there was no history of any ptosis, double vision, facial weakness, swallowing difficulty, or hearing loss. There was no history of stiffness or thinning of limbs, weakness of limbs, or sensory complaints. There was no history of weight loss or loss of appetite, no shortness of breath, palpitations, or chest pain, and there was no toxin or drug exposure. Past history, she's not a known case of hypertension, diabetes, hypothyroid, or epilepsy, and she doesn't have any significant family history. She consumes a mixed Indian diet and has normal sleep and appetite, and is a non alcoholic and a non smoker with no addictions. Her menstrual history is normal with regular cycles, and her obstetric history, she has two kids, G2, P2, A0, and L2. Drug history, there's no significant history of either therapeutic or recreational use. Summary. 26-year-old female with no significant past or family history, presented with high-grade fever, followed by involuntary brief jerky movements of limbs, predominantly while performing activities, probably
No,
action myoclonus, with cerebellar
this is
ataxia and with
Anjala.
abnormal eye movements and blurring of vision, which could be a probable opsoclonus, without any cognitive, motor, sensory, or bowel bladder involvement.
Rohit, wait there.
Yes.
Neeraj sir, any comment at this point from you?
I think,
Lux.
uh-huh. Yeah, Lakshya is there.
So you go
So,
ahead, Neeraj. I'll come up to you.
no problem. So I think probably she has very nicely summarized, and the history was very nicely taken. All the negative histories, pertinent negative histories were there. So I think probably is what the patient is a 26-year young female. So for the students, when you get a young patient and then they have a movement disorders. So some movement disorders is there, which probably she's trying to highlight. So we have to keep in mind that when you are dealing with movement disorders, of course, examination is important, but then history-wise also, you will have a lot of things to say. So she has told about some jerky movements, some eye movements, and she has categorized that into possibility some opsoclonus, and she has told that patient has imbalance. So it depends on how you want to approach. So first is the phenomenology which you can take from the history. So that is important. So the history, there are three different phenomenologies which probably what this lady has, and that has been summarized in the very nicely in this slide. She has some jerky movement, then she has some imbalance or ataxia, and then she has some eye involvement. So now we need to combine these three, and that is how we can come to the conclusion like what are the different phenomenologies which she is having. And we have to remember that these have all happened in a short period of time. I think 10 days history was there, no, Lulu?
Yes, sir. 10 days, sir.
Okay. So the 10 days, so once you have a phenomenology, then the next. Hello.
Can you mute everyone else?
Yeah. So can we start, Lulu?
Yes, sir. Yes, sir.
Yeah.
Continue.
So now we have a phenomenology, and now the phenomenology now we have to find the etiology. So for movement disorders and other neurological disorder, there is a big difference. When we try to discuss a case of neurology or general neurology, leaving the movement disorders aside, mostly our work is to try to find out where is the lesion or neuraxis, where you localize the lesion, and then what is the lesion. Well, in movement disorders, what Lolita has very nicely presented, already we have a phenomenology, and mostly we know that of movement disorders usually will have a phenomenology which probably we will be localizing around the structure, the gray matter nuclei, or we will be localizing to the cerebellar or its connections by and large. And of course, with myoclonus in picture, it can have several localizations, but then things revolve in and around the areas which are important for movement disorder. So probably the localization probably is not that difficult. So it's a phenomena which probably will be more important for us to understand, and probably the video will tell us more about it. And since it's a 10-day illness, so for a
Yes, sir.
10-day illness, probably we are dealing with something which has happened acutely. And she had fever also. That's what was there in the first slide. So probably there might be some inflammatory pathology, which probably likely to be some infective in nature. So that is one etiology. Then, of course, although she has ruled out the drugs, and we don't know exactly what because drugs something for the residents and for all the young fellows, because the drugs are something which it's difficult to rule out unless until you have to dig deep. Many times patients may not tell us that what drugs they are taking, because they may be taking it over the counter. So that is also very important when you are discussing with the when you are trying to narrow down the etiology. And apart from that, of course, the inflammatory, or to be more precise, the infective, then drugs. And then, of course, some acute event which can have happened because of the infection, maybe some metabolic derangement or some uh, or something like that, that might be triggered, because fever can be a trigger factor. It can be a trigger factor for some metabolic or
Yes,
some
sir.
autoimmune. So these things always, whenever a fever heralds a movement disorder or any, especially I am discussing more for movement disorders, then probably it's something which might be related to autoimmune or a metabolic, and the fever has just triggered it and it has gone. Or it may be really cause of that, but then the pathophysiology may be something related to the immune. So I think basically this is what we are dealing with right now. Maybe Lakshya highlight.
Thank you.
Yeah. Lolita described this case. Actually, the I think we can approach this case before going into the etiology. We can approach this case in many ways. Number one, this patient has definitely a this patient has appendicular ataxia, as he was mentioning. Am I audible?
Yes, Lakshya, please
Yeah,
go ahead.
as Lolita was mentioning. So this attack, you can approach this case through this ataxia. Or the another point she has nicely mentioned that this patient might be having some jerky shock-like movement that points towards myoclonus. So once you can, again, the second part is you can go through the second phenomenology that because I think this is one of the predominant phenomenology that the involuntary movement, jerky movement, that is most likely to be a myoclonic jerk. So if you think about the myoclonic jerk, if you approve, then you have to classify myoclonic jerk in different category by the age of onset, then by topography, whether you have to mention whether it is a focal myoclonus, segmental, generalized, spinal then again, according to the origin, cortical myoclonus or subcortical, then proprioceptional myoclonus, spinal myoclonus again, and based on the etiology, it could be physiologic, then essential, then the secondary, then epileptic myoclonus. So in history, these things should you take into account. Whenever you describe myoclonus, you should describe it as per the headings I have mentioned you. There's as per etiology, like physiological, essential, then the epileptic and secondary myoclonus, and then acute and chronic this way. So we have broadly, we have ataxia and we have myoclonus here. So you can approach this, and this, the Niras has already shown the way how we should proceed in a very case of a movement disorder case. Like we go by phenomenology, then you localize the lesion, and then you find the etiology. Okay,
Thank you,
Lulu.
Dr. Lakshya. Thank you. Then we'll go ahead with the, please go ahead, Lolita.
So the possible localization after the history, she's probably having action myoclonus, mostly of the brainstem origin, as they were saying that there were jerky movements of the whole body. Probably could be a brainstem myoclonus. And ataxia can be a pancerebellar ataxia because there is limb ataxia as well as gait ataxia because of imbalance while walking. And there was also smearing of food along with dysarthria and some abnormal eye movements. So from the history, we have established that it's a case of myoclonus ataxia syndrome. And to approach it, it can be divided into, based on the onset, into a childhood onset or adult onset. And each of which can again be divided into with epilepsy and without epilepsy. Our patient, it is a case of adult onset myoclonus ataxia syndrome without epilepsy. So any patient that is coming with an adult onset ataxia, myoclonus ataxia syndrome without epilepsy, we should again look for other associated features based on which we can think of these possible TDs. If there is associated tremors or renal failure along with proteinuria, we can think of myoclonic epilepsy type 4 with or without renal failure. If there are associated hypogonadism with peripheral neuropathy and pyramidal signs cognitive decline, we can think of autosomal recessive spinocerebellar ataxia 16. And if there are nystagmus or any saccadic intrusion or cognitive decline, we can think of a spinocerebellar ataxia. If there is associated Parkinsonism with any autonomic dysfunction or any inspiratory size or dystonia, we can think of MSA. And if there is any opsoclonus or associated neoplasms or infection, it could be opsoclonus myoclonus ataxia syndrome. Like our patient who's having no epilepsy and is having a probable opsoclonus along with infection. So the most probable diagnosis is opsoclonus myoclonus ataxia syndrome. So my provisional diagnosis first is opsoclonus myoclonus ataxia syndrome, mostly a para-infectious etiology, or it could also be a brainstem encephalitis, considering that the localization is like midbrain and pons after infection. On examination, she's moderately built and nourished. She was conscious, oriented to time, place, and person, and her blood pressure is 110 by 70 mmHg, measured in right arm supine position. Pulse rate is 80 beats per minute. Respiratory rate is 14 per minute. Temperature is at the time of examination was 98.3 degrees Fahrenheit. There was no pallor, icterus, cyanosis, clubbing, lymphedema, or lymphadenopathy or edema. There is normal hair and nails. But on general examination, we found a black black lesion on the medial aspect of her foot, which could be an eschar, considering that she presented with fever. But it is not a usual area of presentation for an eschar, but was present on the medial aspect of the foot. Higher mental functions. She was conscious, oriented with normal behavior, no emotional ability, normal intelligence, and intact memory. Her MoCA was 28 by 30, and she had cerebellar dysarthria or ataxic dysarthria. On cranial nerve examination, she was a 346. She was having a broken pursuit, and saccadic intrusions were present, where she was having bilateral, involuntary, rapid, jerky, chaotic, multidirectional movements. That is, the movements were present in horizontal, vertical, and torsional plane without an intersaccadic interval, due to which we've diagnosed it as opsoclonus, as it is multidirectional without an intersaccadic interval. The rest of the cranial nerves were normal. And on motor examination, her bulk, tone, power, and reflexes were normal, and her plantar was flexor bilaterally. Here in this video, we can notice that she's having rapid involuntary, brief, and multidirectional saccadic intrusions. And she's also having a multifocal action myoclonus, which can be noticed in her limbs, trunk, and neck, which are more proximal than distal, and mostly noted when she was in sitting position or while trying to stand, and it was absent in rest. And no stimulus sensitivity was noted to either touch or sound or light. And gait, she needed a two-person support to get up from sitting position and to walk. When she was walking with a wide-based gait with intermittent jerky movements of the limbs, trunk, and neck.
Neeraj sir, do you want to comment anything regarding the movements at this point?
Yes. So she has already
Lohita, can you play the video again?
Yes, sir.
Okay, Lakshya has very nicely described about the jerkiness, the approach to myoclonus. So this is so the eye movements. Let us come first to the eye movements. So what I think it's obvious that probably there is some slow. The video is going a little bit slow, but then the saccadic movements which are happening, they are, as she has told, chaotic. Although the video right now, which probably is there a little
Yes,
bit
sir.
slow, Lulu. It is not very fluid, but then we could see some saccadic jerks going on, and they are in multiple directions. So for the residents, it is sometimes like for young fellows, like this is the saccads which are there. They are normally when we make a saccad, you have to scan something and then you have to focus on something. So when here she is having great difficulty. So saccades are repeatedly happening, and this is happening in all directions. Normally, sometimes it may happen in horizontal, then it's flutter. But as she has rightly told that it is happening in all directions, so that is why they have labeled as hypoclonus, or we also call some sacchadomania. So that is the saccades, and the second is that what she has told about the hand jerks and the leg jerks that we are trying to make out. Video little bit
Choppy.
actually it
Okay.
is it
Dr. Lohita,
freezes in between.
can you stop your video so that you will have a good internet bandwidth? You stop your video.
Yes,
Uh,
sir.
uh, uh,
Now play.
एकदम पछरे छु नि देखिछि पुरा
so uh, yes, Soumya has thrown up a question: is some chorioarthroid? I could not read the complete question, but I think this is a very video quality is little bit difficult to comment. But if it is a good quality video and if there is a fast jerk, then probably it will favor more of a myoclonus. But Soumya might be right. If it is say slow breathing movements or dancing movements or fidgety movements, then probably it will go towards a chorioarthroid. But then as she has said in the history that things were falling from hand, and I believe that probably there might be some jerk, as Lakshya also discussed the approach to myoclonus very nicely. So if this is a jerky component which is fast and the things are falling from hand, then possibility of a myoclonus is more likely than a chorioarthroid. Of course, a good video would have made things more clearer. And
The video is
the
good,
next
but I say the network
Oh,
bandwidth
sorry.
is
I
not
mean, I did
enough.
not. Sorry, Lulu, not the good video,
No,
the good quality of
not at all.
this video while presenting.
Uh,
So, so I'm sure if you are there, video will be good. So the next thing, what I think we are looking at is that gait, which she has shown that she was having great difficulty in walking, and she had a lot of. She was walking with a wide-based gait. And I think she tried to show, did she try to show any movements or this finger nose movements or heel nation? I could not make it out, but now things are looking bit better. The video looks better now. So she is having difficulty in walking, and she has some truncal component also. So she
Yes.
has this truncal component where, so it seems to be wide based gait with some truncal instability that may be related to this ataxia, or at the same time, even if jerky movements are there, that also can sometimes generalized jerks can also have the myoclonic component can also resemble things like this truncal instability or limb instability. So again, this myoclonus is if predominant, that may sometimes uh, add to the component of imbalance or the truncal instability. So I think these are the three major components which she has described in the history, as well as I think now in the examination also we are seeing. But of course, the quality of the video which is coming out, that is something which probably is not good enough to really know about the rapidness or the character of the jerks. So, and Lakshya, you want to
Yeah, Neeraj,
add on to that? Yeah,
Neeraj,
please go ahead.
now, Neeraj, you have described it very elegantly. The problem is this the frame rate is not that very much encouraging this video. It's not
Yes,
so
yes.
fluid, maybe because of bandwidth. So what I can see, this lady has definitely truncal ataxia. She is trying to keep up her erect posture. So she is swaying from side to side, and on the top of that, there is a myoclonic jerk also there. So that is why I think Dr. Dr. Nayak has mentioned about this chorioarthroid movement. So truncal movement superimposed on myoclonic jerk. I think that is creating more puzzle for viewers. I think, as you have mentioned, if video was very smooth, then we could have come to the conclusion very nicely. Otherwise, it looks like truncal ataxia is there. Then she has appendicular ataxia. On top of that, she has a generalized myoclonic jerks, and obviously broad-based gait, as you can see from her stance. Yes.
The catheterization, sir, is due to patient is
Yes,
immobilized, so
yes.
that's why she
So
was
I think,
catheterized.
yes, I was coming to that. I think Lulup, I think
Yes.
Dr. Soumya is raising all the pertinent points. So, so I think catheter, you're right, because the patient probably is immobile. That might be one of the reasons. Second, if there is a bladder involvement, then probably things will
Correct.
become a little bit more tricky. So,
Yes, sir. The other is actually in the first day when we have seen the patient has severe ataxia, and also multiple myoclonus were there. So that's why she was completely bedbound at that time also. She was not able to do any useful work that time also. So this video actually after 2 days of starting treatment otherwise, but it is more severe on the first day. So, so that is the thing. Okay, Loita, please go ahead with your evaluation and discussion part.
Sensory examination was normal, and cerebellar examination, finger nose test, finger test, rapid alternating movements, rebound phenomena, heel shin test, everything was impaired bilaterally. Meningeal signs, she was having neck rigidity, and but Koenig's and Wierenski's sign was absent. No peripheral nerve thickening, skull and spine were normal, and other systemic examination was normal. So after examination, the summary is a 26-year-old female with no significant past or family history, presented with high-grade fever, opsoclonus, multifocal action myoclonus, and pancerebellar syndrome with meningeal signs without any cognitive, motor, sensory, or bowel bladder involvement. Localization, opsoclonus can be localized to brainstem due to the omnipause damage to the omnipause cells in nucleus raphe interpositus and cerebellum and its connections. The action myoclonus can be localized to the brainstem cerebellar circuits and ataxia, the pancerebellum and its connections. As we've already discussed, myoclonus ataxia syndrome, adult onset without epilepsy. Um, Here, the patient was also having opsoclonus along with infection. So, our most probable diagnosis is opsoclonus myoclonus ataxia syndrome. This is another slide which shows the possible DDs if an adult onset myoclonus ataxia syndrome patient presents with epilepsy. Then, depending on the other associated findings, if there's any retinopathy with cherry red spots or dysmorphic features, we can think of sialidosis. And if there is any cognitive decline or behavioral disorders, along with chorea and pyramidal signs, DRPLA can be a possibility. Or we can think of if multi-systemic involvement like hearing loss or any dysphagia, dysarthria, short stature, and stroke-like episodes, MAF and MELAS can be a possibility. And if there is Parkinsonism with rapidly progressive dementia, prion diseases like CJD can be seen. Parkinsonism with cognitive impairment and behavioral disorders. We can think of epilepsies like progressive epilepsies like NCL and Golgi ataxia and primary coenzyme Q deficiency. Along with these symptoms, if someone presents predominantly with the gastrointestinal symptoms, then celiac disease is also a possibility. So if someone presents with the myoclonus ataxia syndrome with epilepsy, these are the DDs that can be thought of. Approach to nystagmus or saccadic intrusions. First, we have to see if there is a slow wave. If slow wave is present, then it can be categorized as nystagmus. And then we look for if the slow wave is followed by a fast wave or no. If there is a fast wave, it is called a jerk nystagmus, and if only slow waves are present, phases are present, it is called a pendular nystagmus. The jerk nystagmus is usually present in peripheral vestibular nystagmus or central vestibular nystagmus. Jerk waves is usually associated with vestibular nystagmus and gaze evoked nystagmus and downbeat upbeat nystagmus. Whereas the pendular nystagmus is usually associated with the infantile nystagmus or nystagmus due to vision loss, oculopalatal tremors, or acquired causes of CNS etiology like multiple sclerosis. If there is no slow wave, then it is a saccadic intrusion or a saccadic abnormality. Then we look for if there is an intersaccadic interval. If it is present, it can be either a square wave jerk or macro square wave jerk or macrosaccadic oscillation. If intersaccadic interval is absent, then opsoclonus and ocular flutter are the possibilities. If it is happening only in a horizontal plane, it is a ocular flutter. And if it is happening in chaotically and in multiple directions, then opsoclonus is the diagnosis. So in our case, she's having it in multiple directions. So opsoclonus is the diagnosis. Pathophysiology Pathophysiology of opsoclonus. It is due to the omnipause neuronal inhibitory tone on the saccadic burst neurons and the fastigial nuclear disinhibition in the cerebellum, which is causing the uncontrolled rapid eye movements along with the myoclonus. While opsoclonus is only one of the opsoclonus is one of the eye abnormality associated with myoclonus, but myoclonus is the most common dyskinesia which is associated with opsoclonus. So opsoclonus-myoclonus syndrome, the most common etiology is paraneoplastic, followed by idiopathic causes like parainfectious, where HIV, Mycoplasma pneumonia, Salmonella, cytomegalovirus, herpes virus, and rickettsial organisms are some of the common causes of parainfectious etiology. So the provisional diagnosis is subacute meningoencephalitis with opsoclonus myoclonus ataxia syndrome, mostly of parainfectious etiology. And the common etiologies associated with opsoclonus myoclonus ataxia syndrome first is paraneoplastic, and the most common cancers associated with it are small cell carcinoma of lung, breast carcinoma, and ovarian carcinoma. And the most common antibodies associated with it are anti-RE, anti-MA2, anti-CRMP5, anti-HU, and anti-GAD65. And for the infectious causes, HIV, like I've already mentioned, HIV, pneumonia, salmonella, hepatitis C, CMV, COVID-19, etc. are all the common organisms. And then we
Dr.
have
Lohita,
toxic or metabolic
Dr.
causes
Lohita,
where
Dr. Lohita, there is one question from Dr. Somedar Naik. So, what the corroboration with XR you have mentioned in the general examination?
that eschar is usually associated with scrub typhus or any anthrax infections. These are usually associated with an eschar. So that kind of helps us with the telling like like which organism has caused the infection. Mostly scrub typhus. So the toxic metabolic causes drugs like organophosphates, toluene, and heavy metals like lead, mercury, arsenic, and drugs like phenytoin, lithium, SSRIs, cocaine, amantadine, amitriptyline, and metabolic causes also rarely like hepatic encephalopathy, uremia, hypomagnesemia, hypocalcemia, Crohn's disease, and hypoxia can also sometimes like rarely present as opsoclonus myoclonus ataxia syndrome. And if all of these have been ruled out, then idiopathic can be thought of. So investigations on her routine investigations, her CBC, Triple H, and RFT were normal, and on LFT she was having transaminitis. And CSF study was done where her total cell count was 10, which was lymphomononuclear predominant with a normal protein. Her dengue and MPICT were negative. Her ultrasound whole abdomen was normal, and her EEG was also normal. Then we got an MRI brain done. These are the T2 and flare sections showing the midbrain pons in the cerebellum, which were normal. Then we've also sent for an IgM scrub typhus using the ELISA method, which was positive. So the final diagnosis is subacute meningoencephalitis with opsoclonus myoclonus ataxia syndrome due to scrub typhus, which is due to which we've found the S-char. And we started her on injection doxycycline 100 mg IV BD for 14 days and injection methylprednisolone 1 gram IV OD for 5 days. And this is day 12 post admission, where we can see that her opsoclonus has improved. It's still present, but it has improved from before the treatment. And her myoclonic jerks also have improved from before. And previously, she was unable to perform her cerebellar test, like finger nose test, properly. And now, even though there is some intentional tremor still present, it has like the cerebellar examination also improved from before the treatment. And before she was unable to, she needed two-person support to get up and walk. Now she's able to get up from the chair by herself and also walk.
Wait a minute.
So,
Wait,
review
wait a minute.
Wait.
Wait a minute. Neeraj sir, I have a question for you. So, how frequently you used to see this kind of SR in a patient of scrub typhus?
Actually, here I have not seen, but in Rishikesh, there
Yes,
we
sir.
had lot of patients, and I think this is quite prominent. So in Ishchar, probably we had even reported 7 case series, but of course the patients they had GBS,
Yes,
Guillain-Barré
sir.
syndrome, because as you know, this scrub typhus they can manifest in several ways, and one of the ways is like they have a GBS like manifestations. And there out of 7, I think we had 3 patients with discharge. So you do get these discharge, and that is something which probably is quite a clue. Like we used to see, I think we had seen quite a good number of patients. 7 we reported with GBS, but then if we always used to search for the discharge. So if we have a discharge, then probably scrub is something which we must rule out, as rightly said by Dr. Lolita. Yes.
But this patient has that black spot in the foot only, not in the usual site of
Okay.
SR.
Okay.
So that is a unusual point.
That is unusual, but I think again I'm not sure if there is any place which will be immune to ishtar, and
Yes,
but
sir.
of course there are places which will be more commonly seen, as you said. But then just not having an ishtar, I don't think there's a place which will be immune to not developing the ishtar. Yes, yes.
The next,
But that was a good clue.
yes, sir. Yes, sir.
Lulu,
Yes. Ha.
yeah, I just want to add one comment here. Lolita has mentioned and shown the video pre-treatment and post-treatment, but I think she has missed a vital point here. So, how do you know what is the Mitchell-Pike OMS rating? Should have done the, this is OMS. Okay, so what it is the scale means Lulu is the master there sitting with you. The moment is the master. So you should document the rating scale that is called Mitchell-Pike OMS rating scale. It has got 6 category, okay? Stance, gait, arm and hand function, obstroplenus, mood and behavior, and speech. Each category has 0 to 3, okay? Or 1 to 3. So you should document this OMS rating before your treatment, then after the treatment. Then you can actually objectify your treatment response, right? So I think that is the point I just wanted to make. You should practice doing the record. You should practice the rating scale actually. Not in this case, some like in essential tremor also, in dystonia also, twister scale like that. Okay.
Yes. I think that's a very valid point, Lakshay,
Yeah.
because mostly, see, you are presenting a case in adult. Mostly we see patients with, because I've seen 2 patients here with neuroblastoma related opsoclonus maclonus ataxia. And this Mitchell-Pike, that is very commonly used in those cases, because that is how we can monitor. And of course, there are modifications are there, which they have reduced to say 3 or 4 out of 6. And and another thing which probably will be interesting, like when we discuss this OMAs, so there are some cases who may have some non-motor manifestations like sleep and cognition.
Yes.
Which probably you will because as you said, this what we are discussing is more of a motor manifestations. So there are non-motor manifestations which will probably be
mood
some
disorder.
patient may have sleep
Mood disorder,
disturbances.
sleep behavior.
And mood disorders, cognition. So that also will be, And interestingly, the list which at the end this Dr. Lolita gave, that had not mentioned neuroblastoma. So I think probably she was discussing more about
I
non
was just mentioning the
neuroblast.
adult
Yes, yes, yes.
etiology.
That's what I'm coming to. That because it was not because mostly this is classically, just for the audience. Classically, you will see this in childhood. This is very, no, adulthood. It is not very common, but in childhood, I mean, they have almost got some prevalence of almost like zero point 0.2 or zero point 0.3 per let's say million
Million,
kids, something
million.
like that. So
Yeah,
that's something. So we should not forget that this is a disorder predominantly of childhood, of a 2 year, 1 year old boy, and
yeah.
many of us must have seen this disorder. So I think thank you, Lakshya,
Mhm.
for bringing that up.
Yeah, last 6 months I have seen two patient, very interesting patient, OMS. The recent one was with the secondary undifferentiated, poorly differentiated carcinoma in the left axillary lymph node, a 6 years old lady. We could not find a primary, but the PET scan showing some suggestion that there could be a suspicion in the left breast. She underwent mastectomy, then even biopsy was negative. So that is one interesting patient. And another
Yes, yes.
patient, she mentioned in the very elaborative slide that if it is not epileptic, if it is epileptic, it could be NCL also. So I have one
Yes.
young boy with optic atrophy. He's around 23 years. Optic atrophy. He started with generalized seizure. Later on, he developed myoclonic seizure, then optic atrophy. When he developed optic atrophy, we sent a whole genome sequencing. Then it came out to be NCL7. So very interesting. If you go by the
Great.
algorithm, then I think the diagnosis is much easier.
Yes, yes.
Thank you. Yeah.
Yeah. And I think this at the end, just final one comment I wanted to make, Lulu. The final localization, what she has discussed very nicely. So that goes to again the cerebellum or the cerebellar connections here, because cerebellum will explain about your ataxia, and the fastigial nuclei she has shown very nicely in her slide. The that disinhibition of the fastigium will give rise to the opsoclonus because it has a direct control over the omnipause. And the third is the cerebellar, thalamic, and cortical connections. That inhibition of on the cortex is released once you have a cerebellar involvement, and that sometimes can give rise to your action myoclonus. And that is what probably she was saying, that what multifocal myoclonus. So probably, and this is nice just for the residents to sum up. So the cerebellum can have myoclonus as a feature, or the cerebellar connections or the fastigial disinhibition can lead to your this opsoclonus, as well as, of course, ataxia will be the part and parcel of it. So I think a very nice case. Thank you.
Thank you. Thank you, Nijay sir and Lakshya.
Yeah. Lulu and Lalita, well presented. Very nice case. Yeah.
Nice case. Nice learning
Yeah.
case. Thank you.
Yeah, Soumya. Dr. Soumya, you remain very quiet today.
Yeah, no, no.
Soumya,
Give me
Soumya was
give me the last
Soumya
word.
was continuously on the chat box. He was throwing questions.
Yeah.
Very busy.
Yeah.
Actually, I was just coordinating, so we wanted to hear both of you as experts on this field, and it was just pleasure to have both of you here and dissecting the case so nicely. And Lulup and Lolita, they
Actually,
presented the
to
case
one
so nicely.
correction, she's not she's Dr. Lohita. So
Loita,
every
okay,
time she's
sorry,
smiling,
sorry.
Lolita.
Yeah. So Loita presented the case very nicely, and I think our ANEI secretary, Dr. Gunjan, he's there. So we would have final word from Dr. Gunjan, who has initiated this CME masterclass for residents only, so that they get knowledgeable and they prepare well they learn from the experts and they prepare well prior to their exams. So if Dr. Gunjan is there, we'll have a final word from him.
Thank you, boss. And I think it was a wonderful discussion. And thank you, Dr. S.D. Nayak. Thank you, Dr. Lakshya. Thank you, Dr. Neeraj
Thank
sir,
you.
Dr. Lulup. I think it was a fantastic discussion, and our residents will benefit Like we are planning to have, like from one state, the presenter will be there and the experts will be there from other states. So this is what we would like to have, and we are trying to involve all our residents. We're trying to encourage them to also become the members of this. So this is what we have started this year, and hopefully each month we'll be having, and we need your support. We need the support of our residents also and our experts also, like Neeraj sir and all. So I would like to thank them again. This will be a recurring feature, and hopefully we like to continue this in future. Thank you.
So thank you, everyone.
Thank you. Thank you,
Thank
Mithun.
you.
Yeah.
Bye bye.
Thank
So
you.
we are
Bye.
ending our session.
Bye.
So
Bye. Bye.
bye bye and good night
Thank
to
you, sir.
everyone.
Bye.
Thank you.
Bye.
Thank you.
Thank you, Lakshmi.
Thank you, sir. Bye.